that you have. As Matt mentioned, I'm an emergency physician. I have 32 years of clinical experience, the last 27 of which has been at St. Joseph Mercy Hospital in Ann Arbor, which is a 550-bed community teaching hospital with a level 2 trauma center and an active graduate medical education program affiliated with the University of Michigan, where I'm actually serving as a clinical member of the medical school faculty. I've also been active in organized medicine, and including the American College of Emergency Physicians and the Michigan State Medical Society. So I'm going to start off with, if I can get this to advance, let's see. So Matt, let's see, what do I want to do to advance here? Here we go. So just in terms of disclaimer, I'm not speaking on behalf of any of these organizations. I am honored to be a member of the PNHP Speakers Bureau. And let me start off by saying, why bother trying to convince organized medicine to support single payer? A lot of people think this is a very quixotic journey, that I'm wasting my time, that you can't convince doctors of this. And I've been doing this now both for the American College of Emergency Physicians and the Michigan State Medical Society for the last 8 years. I've been introducing resolutions before the Council for ACEP or the House of Delegates for MSMS. And there's several reasons I do this. First of all, to start off with, you're dealing with a captive audience. When I get up there and I talk about my single payer resolution, I've got anywhere between 200 and 300 people in the room. Obviously, not all of them are paying attention, checking emails and so on, but at least my sense is I'm going to get a much better participation than I would be if I just put up a poster or said I'm going to be talking about single payer. Secondly, it gives me an opportunity to improve speaking and debating skills. There's always going to be people that are going to get up there and they're going to debate anything you say, so you need to be prepared to answer them. Third, it's important to hear what the opposition says. We've come a long way from the time when I started this, where somebody would just get up and say, single payer is socialism, everybody knows it, and they just sit down. Some of them actually have some pretty good arguments against it, and it's important to hear what they have to say. There's always the people getting up there that are going to be the detractors, that are going to have the cat calls. I was doing one presentation in Boston when someone stood up and asked me to cite the journal article and the authors. So it's important you be able to handle that. And finally, whenever you do these, you often will get invitations to speak to other groups. So it's sort of a way of getting your name out there, and as well as speaking about PNHP. Now, you would think that, on the next slide, you would think that single payer would be a no-brainer for emergency docs, because we have a de facto single payer environment as it is right now. We see everyone with no questions asked. We see them regardless of their insurance status or ability to pay. We have, compared to our other colleagues, relative autonomy in terms of diagnostic workup and treatment. We get a single check every month. And so that if someone threw the switch and we went to single payer, nothing would change in the emergency department in terms of the clinical approach to the patient. It's my position that we would probably get paid just as well, if not better, because, among other things, we would finally get funded for our obligatory services under the Emergency Medical Treatment and Labor Act, which requires us to see everybody regardless of their financial status. When Congress was working on that 30 years ago this month, they didn't fund it. So they required us to see everybody without making payment available. And there simply is no business case for a private for-profit health insurance plan to pay for those who don't have the ability to pay for their emergency services. Third, under a single payer system, it would reduce the cost of billing. Typically, emergency medicine groups now devote about 10% of their gross to their billing company, and that would be drastically reduced under a single payer system. Fourth, it would eliminate the phenomenon known as balance billing. That's what you have when you go to a hospital that's a member of your health plan, but the emergency physician is not. So emergency physicians have tried to balance bill the patient for the difference between what the health plan wants to pay them and what they think their services are worth. That's been outlawed in California, and I think other states are doing it too. Fifth, you have improved patient follow-up, because under a single-payer system, you'd have a much more robust primary care system. It'd be a lot easier to get people in to see primary care physicians after they've had their ED visit. And finally, it promotes tort reform, because to the extent that people who have been, who see themselves as victims of a medical misadventure will sue so they can get their bills covered by the deep pocket. That wouldn't be the case under a single-payer system, because they would all have pre-existing coverage. So briefly, what's wrong with American healthcare in a few slides? First of all, access issues. Even with the Affordable Care Act working like it should, you're still going to wind up with 25 million uninsured folks by the end of this decade, and then millions and millions more that are going to be functionally underinsured, which means that they have insurance, but they're paying so much out of pocket that it isn't doing what it's supposed to do in terms of mitigating the financial consequences of catastrophic illness or injury. Secondly, there's quality issues. A famous study that came out about 10 years ago showed that Americans receive high-quality care only about half the time. Of course, the IOM report that came out 15 years ago that showed up to 98,000 Americans die as a result of unintended medical errors. And then next slide, the cost is enormous, as you all know, $2.9 trillion, or about $9,000 per person, representing about 17.5% of the GDP. There's no other country that comes even close in terms of that. The average cost now of insurance and out-of-pocket payments are at least $20,000 a year, according to Milliman. So obviously lots of things wrong. This graph here shows the changes in premiums, wages, and inflation since 1999, and health insurance premiums now are about 3.5 times higher than the increase in workers' wages, and about 4.5 times higher than the increase in general inflation. And this is getting worse every year, even despite the Affordable Care Act. Hospital billing and administration costs in the United States compared to Canada, it's about 4 times greater in the U.S. as opposed to our neighbors to the north. For physicians' office expenses, it's about 3.5 times greater in the United States compared to Canada. Insurance overhead is enormous when compared to other countries in the Organization for Economic Cooperation and Development. Closest is Switzerland, and they have basically a government-regulated private system, and we're still higher than they are. And not only that, but under the Affordable Care Act, the insurance overhead is actually increasing every year. The yellow bars represent the insurance overhead cost post-ACA, and the blue bars there next to them represent pre-ACA insurance costs. So the point is the Affordable Care Act hasn't really done anything to mitigate the increasing cost of health insurance. Medical bankruptcy, about 6 out of every 10 personal bankruptcies now are the result of medical illness or injury or the costs that are attendant to those problems. It represents a 50% increase in the 7 years between 2001 and 2007. It affects about 5,000 families each and every business day, and as you can imagine, most of these people that are affected by medical bankruptcy are middle class. And the amazing thing is 3/4 of them had insurance at the time of their bankrupting illness or injury. So if the whole point of health insurance is to mitigate the adverse consequences of catastrophic illness or injury, clearly that hasn't worked for the majority of the folks that are filing for a medical bankruptcy. And I should point out that the study that was published a number of years ago showed that even with the health reforms in Massachusetts, the insurance and reforms there still was a high level of medical bankruptcy. And this is one of my favorite slides here. This shows the growth in selected components of the American healthcare workforce over the last 45 years. And you can see down there at the bottom in the yellow, the size of physician workforce has gone up about 250% between 1970 and 2014. And during that same period of time, the growth in clerical people, managers, administrators involved with American healthcare has gone up 3,000%. And we all know this. If you go to a modern hospital now, there's 1 or 2 floors that are completely devoted to billing and coding. Some hospitals, like mine, actually do it off-site. They have their own building now for billing and coding. And if you go to a physician's office, you're going to see a lot of people behind the desk. Last time I was at my doctor's office, I counted 4 people behind the desk that were on the phone or in front of a computer screen or doing filing. So it's pretty obvious that a lot of the money is going toward administrative costs and not to increasing access and reducing care for the average American. So if you look at the problem here, the focus has been on alternative payment systems, things like bundled payments, accountable care organizations, and the like. And the elephant in the room that everybody's missing is the rapacious insurance companies that are sucking up a lot of the healthcare dollars. So the question is, when we went through this healthcare reform more than 5 years ago now, why didn't we try single payer? It certainly would have been a lot simpler. It wouldn't have resulted in the Rube Goldberg situation that we have now under the Affordable Care Act. And what I do when I lecture to people, I start off with definitions because a lot of people don't know what we're talking about with single payer. So to start off with, universal health care simply means that everybody is covered. So-called socialized medicine is the situation you have where you have universal health care that's publicly financed, but you're relegated to be seen by a government physician and be treated at a government hospital. Single payer, on the other hand, is where you have universal health care that's publicly financed, but this time you have the luxury of going to a private physician and you're treated at a private hospital. So examples would be Canadian health care and United States Medicare. Single payer would cover everybody. It would reduce the administrative inefficiencies inherent in a multiple payer system like we have now. It would sever the link between employment and health insurance, which might have been okay during the Roosevelt administration, but makes no sense now in the 21st century when you have people that have a lot of mobility in terms of job and geographic relocation. It would allow and preserve and enhance consumer choice of providers. It would reduce gender, ethnic, racial, and income disparities in healthcare. It would be publicly accountable. It would cover all reasonable medically beneficial services based on evidence. It would preserve and enhance the patient-physician relationship. It would eliminate cost sharing on the part of patients, or at least reduce them. It would promote the ability of American businesses to be competitive in the global marketplace. It would promote and enhance primary care services, and as I noted, it would affect meaningful tort reform. If you think about it schematically, what you're doing now, you have over 1,200 insurance plans, and what you're doing is you're basically consolidating those into one single plan, and by doing that, you're capturing efficiencies of scale, and you're reducing administrative waste and eliminating bureaucratic duplication. So, in summary, single payer is the only system out there that would synergistically and simultaneously meet all 3 goals of healthcare reform, which would be expanding access through universal coverage, controlling costs by consolidation of administration, and preserving choice of physician and hospital. Only system out there that would do all 3 of those things in a coordinated way. So the rest of this, for the most part, is going to be discussing the 7 myths of single-payer health insurance. I love this slide because this is somebody that showed up during the town hall health reform debates in 2009. I believe this was from South Carolina, and if you look at the person, it looks like he's probably Medicare eligible. He probably has no idea that the Medicare that he is getting is government financed. So I like that slide, plus the fact that the spelling error. So the number one myth, the alpha myth, is basically that single payer is socialized medicine, un-American, quote unquote. That's not true because the government would not own hospitals under a single payer system, and physicians and nurses do not work as civil servants. As I mentioned, it's government financed and not government run. The feds act, if you will, as the middleman in terms of premium collection in the form of taxes, but they don't, quote unquote, run healthcare. You don't have a one-size-fits-all system, and the analogy that I often use is the interstate highway system. The government does not build the highways. It goes out and hires private contractors to do it. Yes, it may tell you how high the bridges have to be or how many feet the shoulders of the road have to be, but it doesn't actually go out there and physically build them. And the government doesn't tell you when and where you can drive. It doesn't require you get a pre-authorization if you want to carry 2 or 3 passengers. It doesn't require you to call an 800 number each and every time you want to tow your boat. And when you're driving from one state to another on the interstate, you're going on the same road at the same speed in the same car with the same driver in the same direction. You wouldn't have to get out and change cars or drivers, which would be analogous to what you'd have to do if you switched jobs or you switched your state of residence under the insurance plans that we have now. So Medicare, as I mentioned, is an example of a single payer model. It's universal, it's portable, publicly financed. The enrollment is automatic. It's just amazing. 50 years ago when Medicare was signed into law by President Johnson, basically all you needed back in the following year, 2006, when it first started enrolling, or sorry, 1966 when it first started enrolling folks, all you needed was Social Security and a birth date prior to 1901, and you automatically got enrolled. You didn't have the exchanges. You didn't have to worry about declaring your income, your family size, who you worked for, who you used to work for. Incredibly easy to do. It was not linked to a job. It was available universally in all states. The administrative costs are targeted at about 3% of the overall budget. They pay physicians on time, meaning within 30 days, more than 90% of the time. And if you ask people in general about it, 60% favorable rating. If you ask seniors, it's as high as 80% favorable rating. So everybody's worried about we can't have single payer because we'll have big government interfering with our lives, when they're missing the real problem is the huge healthcare lobby, including the insurance companies and big pharma. The second myth, which I love to talk about, is related to misconceptions about Canadian healthcare. And if we went to a single payer system like they have in Canada, everything would just fall apart down here. Well, if you look at the cold hard facts, Canadians live about 2 years longer than we do, despite comparable rates of smoking and alcoholism. Canadian babies have lower infant mortality. Canadian citizens are less likely to have an unmet medical need. They're less likely to skip a recommended test or not see a physician or not get a procedure or not get a prescription filled. And yet, despite all that, Canada spends roughly 53 to 55% of what we do on a per capita basis. There's absolutely no evidence that thousands of Canadians are streaming across our borders every day for routine health care. I've worked at 2 very large hospitals and medical centers within 40 miles of the Canadian border. I can count on one hand the number of Canadians I've seen in the last 27 years. And one of them, I remember, he was in a car accident. And the first thing he said to me was, send me to Windsor, because he knew what the expenses would be. And obviously, he was there not by choice. So it just isn't true that all these Canadians are coming across their borders every day for routine health care. There is no evidence of massive immigration of Canadian physicians because they're unhappy up there. And if you take polls in Canada, they show consistently that 80% or more are satisfied or very satisfied with their healthcare system. You know, with the similar polls in the United States, show nowhere near that number. So here's the study that was published in 2002. They went around and they did surveys of outpatient facilities in the United States. They said, well, how many Canadian citizens have you seen in the last month? And 80% of them said either none or one Canadian per month. And if you look at 18,000 Canadians in Ontario, I believe, that were surveyed, only 90 of them, 0.5%, had received any medical care in the United States, and only 20 of them had gone to the U.S. on purpose. Are there Canadians who come to the United States? Of course. Are there Americans that go to Canada? Of course. Americans have medical tourism just as they do in Canada. What about clinical outcomes? Everybody thinks that care in Canada is inferior. This was a study that was published 8 years ago. It was sort of like an analysis of 38 published studies showing that things were better in Canada in 14, they were better in the United States compared to Canada in 5, and there was essentially no difference in 19. So if you have breast cancer, you'll do better in the United States. If you have ENT cancer, if you're on kidney dialysis, you'll do better if you're in Canada. And then what about all those waits you hear about? How about all these people standing in line for care? More than 80% get their elective surgeries within a reasonable time. The median wait for elective surgery is about 4 months. Don't think that isn't true in the United States, particularly if you have Medicaid or you're uninsured. Good luck getting a colonoscopy, elective colonoscopy, anytime soon if you have Medicaid. There is absolutely no evidence of people waiting for emergency appendectomy or emergency bypass or a PCI. There are reasonable explanations for the waits when they exist. There was one study reported in the New York Times that said, there was this huge waiting list for cardiovascular surgery, and it turned out they were waiting for a couple of well-known cardiovascular surgeons. So they weren't waiting for the service, they were waiting for the doctor. Don't think that doesn't happen here in the U.S. Here's a study looking for the last 10 years. Canada has actually had a net gain of physicians. The negative numbers there on the right-hand side means there's more Canadian physicians going to Canada than leaving. Here's the income on average for all physicians, about $317,000. Now, I think that's gross, but even if you take away their expenses, which are a lot less than the equivalent expense for a medical office in the United States, they still do reasonably well, in my opinion. And then if you look at the growth in Canadian physician salaries over the last 60 years, there's definitely a curve on the upswing showing that their income is increasing. And if you look at malpractice costs, look what it costs in Ontario for a family physician, about $3,500. Even for neurosurgery, $42,000 for Ontario. Other provinces in Canada, even less. It's hard for me to believe that you're going to be instantly poor if you're a physician in Canada. So in summary, Canada rations health care by urgency and medical need, and we ration health care by income and insurance status. So the question is, which is more egregious of those two? But just understand that every country in the world rations their health care to some extent. I happen to think that looking at urgency and medical need is much more important than pay. The third myth is, what about the market? If we could just fix the market for health care in the United States, if we could just post our prices at the door, if we could make everything more transparent, if we could make people pay more out of pocket, everything would be solved. I like this cartoon because here's a poor soul that walks into the emergency department, and the clerk is saying, there's going to be a little bit of a wait because we have to figure out a market solution to your problem. People talk about the need for more skin in the game for American healthcare consumers, and the fact is we already pay more out of pocket than any other country in the world. And, is healthcare a consumer good in the same sense of a new car or a flat screen TV? And then what are you going to do about the uninsured under market-based conditions? Now, Several years ago, President Bush, in an address in Cleveland, said, well, I mean, everybody has access to health care. You just go to the emergency department. Obviously, he doesn't understand that there's a lot of things emergency physicians do really well, but we don't do mammograms, we don't interpret pap smears, we don't arrange for colonoscopies, we don't have any particular expertise in the treatment of difficult to treat diabetics or hypertensives or people with refractory hyperlipidemia. That's not what we do. And I would argue that the emergency department is not the best place to go for basic primary care services, certainly not in terms of continuity of care. Here's an example of why the market won't work. These are some examples of the charges for prices for ankle MRIs in the Washington, D.C. area. And as you can see, they're all over the map. So, you know, that's not a good thing. That's not conducive to market-based care. So what has the market done for health care in the last 20 years? Well, it's an increase in the number of uninsured, a decrease in the choice of provider, consolidation of HMOs into healthcare oligopolies, diversion of healthcare resources into things that are more profitable for hospitals like bypass surgery and new hips. At the same time, underfunding of less profitable endeavors such as public health, trauma care, unaffordable prescription drugs, dissatisfied patients, frustrated physicians, and of course higher costs. That's what the market has done over the last several decades. The fourth myth is that single payer would inhibit medical innovation. As far as I know, there is no correlation between innovation and the way a country finances its health care. Many of the technological advances that we take for granted come from countries that had national health insurance. So we got CAT scans and MRIs from Great Britain. We have laparoscopic cholecystectomies from Canada. The first coronary angioplasty was done by a German. The relationship between H. pylori disease and peptic ulcer was elucidated by an Australian. The first successful human heart transplant was done by a South African surgeon. So there's no correlation between the way your country finances healthcare and the technologies that it produces. And then the largest single source of funding for medical research in the United States is, guess what? The National Institutes of Health, with $31 billion in funding in fiscal year 2010. The leader in medical journal articles per capita is actually Sweden. If you look at the spending on research and development costs for pharmaceuticals per capita, the United States is actually behind Great Britain and Sweden. And examples of medical technology leaders, there's actually more MRIs per capita in Japan, more radiation equipment per capita in France. So that doesn't hold any water, the idea that single payer will inhibit innovation. Private insurances, they have no incentive to fund medical research because of the long lag time between conception of a study and the release of data, and because their enrollees frequently change jobs, the benefits of investment in research will not inure to the insurance companies because by that time the individual has moved on and changed insurance. So the fifth myth is, well, even if it's a good idea, we can't afford it. Well, obviously taxes would go to it, but health insurance premiums would disappear. You would get savings from economies of scale. You would have decreased out-of-pocket payments for patients, and you would eliminate cost shifting and the attendant costs that go with it that you have now. Estimates of savings under a single-payer system range anywhere between $200 and $400 billion, depends on who you ask. If you look at the healthcare cost curves as a percent of GDP in the United States and Canada, they were basically congruent until the early 1970s, at which time Canada's National Health Plan was fully implemented. And if you can see beyond that, there's been a separation. Both countries in cost obviously have gone up, but much faster in the U.S. than in Canada. So there's something to be said for what Canada did in terms of limiting the increase in healthcare costs. The next myth is that, well, under a single-payer system, everybody would be running to the emergency department. We would be having people that would be coming in and getting a lot of services that they really don't need. Well, if you compare emergency department utilization in the United States compared to our neighbors to the north, it's about the same, about 40 visits per 100 individuals. So not a whole lot of difference there. If you look at Taiwan, that went to a national health program in 1995. Prior to that, only about 57% of the Taiwanese had health insurance. 2 years later, that was up to 97%. Obviously, costs shot up in the first year because people had this backlog of medical problems that they wanted taken care of once they got insurance. But after that, the costs have been increasing in Taiwan about 3.5% per year. And there was no significant increase in emergency department visits after healthcare reform compared to prior. And then the final myth is that, well, this may be a great idea, but we'll never get it passed politically. Well, I would argue to that conventional politics is what sustains the mess that we have now, and we have to be careful to distinguish between what is desirable and what is eminently doable. If you think about it, it took over 80 years for women to get the right to vote. It took over 100 years to pass civil rights legislation. And if everybody was putting politics before policy, then those things would never have happened. And, you know, for example, Rosa Parks should have just gotten off the bus. And that's what they said about Medicare in 1965. This shows a picture of LBJ signing the Medicare legislation 50 years ago this July with former President Harry Truman and his wife looking on there. And it took enormous amount of effort to overcoming the politics to get that passed, including, I might add, the vehement, unrelenting opposition on the part of the American Medical Association, where they spent almost $900,000 on lobbying, which was an enormous sum back in the 1960s, assessing every member another $25 to cover the cost of lobbying. It was the most expensive lobbying effort to date at that time, and despite that, it took a lot of political courage, and obviously it was done. If you look at popular support, it typically runs in the 60s, 63 to 66%, depending on how you ask the question and who does the study. It's important to put this out that there's even support for it, even if you tell the person you're surveying that your taxes are going to go up. More than 400 labor unions. I understand now that 48 members of Congress are behind that, and I'm willing to bet a lot more are, but just are not willing to admit it. 3 Nobel Prize winners, several organizations, including PNHP, American College of Physicians, the American Medical Students Association, American Medical Women's Association, APHA, California Nurses Association, lots of groups that have come out in favor of single payer. And obviously, I would like to see that with the American College of Emergency Physicians and the Michigan State Medical Society. If you look at what physicians think about it, 59% support government legislation to establish national health insurance. And down there at the bottom, if you ask specifically emergency physicians, 69% were in support. This was published in the Annals of Internal Medicine back in 2008. And then if you look at Massachusetts, 2/3 support either a single payer or a public option, a lot more than those who supported the 2006 Massachusetts healthcare reforms. You know, you might ask, why don't conservatives embrace single payer? If you look at it, a single payer system would improve efficiency in terms of uniform billing, eliminate duplication. It would reduce bureaucratic control, which conservatives theoretically should like. It would preserve freedom of choice. It would extend health security by promoting uninterrupted health insurance coverage when you go from job to job. and it would preserve consistency of healthcare providers. When you switch doctors, you don't have to worry about being forced to stick with a provider that's in the health plan that, after all, was picked for you by your employer. Why shouldn't business embrace single payer? Seems to me a logical thing because it would reduce the cost. It would, as I've said, promote global competitiveness. It would reduce the incentive to hire part-time workers. You wouldn't have to worry about covering your retiree health benefit costs, which fewer and fewer companies are doing today anyway. Obviously, if your employees had insurance, you'd have a healthier, more productive workforce with less absenteeism. And the bottom line for a lot of employees is that their discretionary income would go up. And this is just a little something that I did on the back of an envelope, going back to what the effects would be for emergency physicians. What I did here was take the National Emergency Department survey data that was published in the RAND report that came out 2 years ago. And then what I did is I plugged in reimbursement data as a % of Medicare using Michigan data. So if you look at the first row there, this is from 2009. Of the 122 million ED visits, about 26,000 had Medicare as the primary payer, representing 21% of the total. And then if you look at Medicare as a reimbursement using Medicare as the standard, that means 21.2% of your reimbursement came from Medicare. The next row, if you look at Medicaid, you had about just under 32 million Medicaid visits, representing 26% of the total. But because Medicaid pays only a little bit more than half of what Medicare pays, then your reimbursement is down to 14% using Medicare equivalent. Commercial payers accounted for 42 million visits, representing about 35% of the total. And because commercial pays 45% more than Medicare does, it represents about 50% of your reimbursement. Obviously, self-pay, which represents 17% of the total, they're paying nothing. And people whose charges were written off, just under 1%, they're paying nothing. So if you look at the bottom line there, if you look at Medicare equivalents, you only get about 86% of what you would get if everybody paid at the Medicare rate. And then on the next slide, I changed things a little bit. I said to myself, what happens if 100% of all the self-pay people paid at the Medicare rate? Then you'd have about, under the current system, you'd have about 103% of what Medicare would pay if everybody paid at Medicare rates. So basically, it's kind of a wash. And I might add, this is before you factor in the transaction costs of dealing with billing and coding companies. So we have a bill that has been reintroduced before Congress by Representative John Conyers here in Michigan. It's the Improved and Expanded Medicare for All bill, H.R. 676. This slide is a little dated, so I understand we're up to 48 co-sponsors now. H.R. 676 would provide a comprehensive medical benefit package. It would allow patients to have a full choice of providers. There would be no co-pays or deductibles. Enrollment would be automatic and would stick with you from year to year. It would be financed through progressive tax financing. Roughly 95% of Americans would pay what they're paying now or less under this legislation, and the cost would be contained through global budgeting, capital planning, and enhanced emphasis on primary care. It would cover everyone. Access to care would be based on need and not the ability to pay. Insurance risk would be managed by risk pooling, and it would be pooled across the entire population. And you would not be limited to seeing particular doctors, hospitals. It would vastly simplify administration, and it would minimize centralized management of care and bureaucracy. So that's H.R. 676. So the bottom line here is that the Affordable Care Act, which depends greatly on the private insurance industry, will not solve our problems in terms of access controlling cost. single payer is not socialistic. It is the only plan, again, that addresses all three goals of health reform in terms of increasing access to care, controlling cost, and preserving consumer choice. As for me, I am making slow progress in getting more people to buy into single payer, and I think the reason is because the younger physicians, the people that are just coming out of medical school who have typically $160,000 in debt, and that are not interested in hanging up their shingle and taking out more debt in terms of a mortgage of buying somebody's pre-existing practice, they're starting to get this. And they just want to practice medicine and not push papers. So if you look at the people that are voting for my resolution every year it tends to be medical students and new graduates and people that are just starting out in practice. So I remain cautiously optimistic that we are eventually going to get this, if for no other reason than the system we have now, the house of cards that we call our current financing system, is going to collapse under its own weight. And also because I believe in the prophetic statement of Winston Churchill, you can always trust the Americans to do the right thing once you've tried all the alternatives. So thank you very much for your attention. I'm happy to entertain questions. Thank you.